Yes.
Okay, Fabio, go ahead. I'm
Okay.
going to unmute and
Okay.
disconnect my camera.
Good morning and good afternoon, everyone. It's a great pleasure to be here today. And first of all, I would like to thank Dr. Gina Brown for being here with us. It will be a really great pleasure. And to have here together the two of the most finest ladies in our specialty turns our day a marvelous one. So it will be a great pleasure to hear from Gina and also from Angelita. Angelita, I would like you to introduce Gina a little bit and talk to her a little bit. Thank you very much.
Yes, good morning, good afternoon to you all. I have to say, this is a huge pleasure for me to be here with you all, my dear colleagues from Latin America, and from my dearest friend in the world, Gina Brown. Everybody knows how much I enjoy your company, Gina Brown. And since we started doing FICARI, our Fórum Internacional Câncer de Reto, you are our special guest. Without Gina, there is no FICARI in Brazil. Gina, you are great. I am very pleased to be here. And you all, Escalante, you all, and Augusto, Isaías, Fábio, I am very grateful for you having opened the Fundação Angelita Habr-Gama. I was very honored last FICARI with this foundation. It was our colleagues, dear colleagues from Latin America, who had this special idea. I think I do not reserve such homage, but anyway, I am grateful and honored. And now, Gina, everybody's waiting for your talk. Thank you very much for
Thank
coming.
you. Thank you so much. And well, Angelita is such an inspiration, and she's the glue that holds us all together, that brought us together in the first place. And were it not for her wonderful organization of the meeting and the colleagues that she introduces us to, and the friendliness and the friendship, I don't think we would be able to have such meetings and share knowledge in this way. So we have all been affected, and Angelita so affected by the pandemic, but yet it has brought us together. We can now communicate and have lectures online together and share information together. So it's a great pleasure to see you. It's not the same as seeing you when we're all together in Brazil, but it's nearly the same. So I feel it's really good to see you all like this, and to be able to talk to you and answer questions and discuss how we can improve the treatment of rectal cancer. That's what we're here for. So
Okay.
I will...
Before that, Gina,
yes?
I would like to introduce Dr. Ricardo Fretes,
Yes.
who will coordinate all the work we are doing today.
Yes.
Dr. Ricardo is the former president of the Society of Cirujanos and also Society of Colorectal Surgeons in Paraguay. He's the former president of Latin American Association of Colorectal Surgeons. So we decided today to choose someone special to coordinate our session. Dr. Ricardo, you have the word.
Muchísimas gracias, muy buenos días y buenas tardes para los que están morando en el otro lado del mundo. Es un privilegio y un honor ocupar esta banca y, por supuesto, agradecer la enorme responsabilidad y honor que me ha conferido la Fundación Angelita Habr-Gama, mi querida profesora. Y cómo ha pasado el tiempo. Tuve el privilegio y el honor de formarme con la profesora Angelita, y una señora que me ha inspirado en todos los aspectos de mi profesión, y por qué no decirlo, en las conductas propias de que son indicativos del don de gente, de la buena persona. Un ejemplo en todo. No puedo jamás dejar de agradecer. Una de las virtudes del buen hombre es ser agradecido. Y profesora Angelita, gracias por haber sido mi inspiración. Hoy tenemos una sesión científica de enorme privilegio. Vamos a escuchar una conferencia de la profesora Gina Brown de avanzada. La resonancia magnética en cáncer de recto ha venido a cambiar rumbos en el tratamiento del cáncer de recto. La señora profesora Gina Brown es graduada de la Facultad de Medicina del King College Hospital. Tiene más de 150 publicaciones referentes a este tema y entre ellos 10 publicaciones que han sido premiadas por el alto nivel científico de dichas investigaciones. Responsable de la formación y despliegue de una alta calidad de la resonancia magnética, su valor en el cáncer de recto, y ha formado a más de 180 equipos colorectales en función multidisciplinaria. Es pionera en la investigación de factores pronósticos por utilizando el IRM, conduciendo a la identificación de predictores claves predictivos para la recurrencia local y enfermedad metastásica al cáncer de recto. Hoy está haciendo esto objeto de ensayos clínicos en fase 2 y 3. Ha desarrollado criterios de estratificación en cáncer de colon y recto y estándares para la presentación desarrollado a nivel mundial y utilizado hoy día a nivel mundial. Desarrolló protocolos de cirugía en el Reino Unido para pacientes portadores de cáncer de recto y definió criterios de resonancia magnética posterior al tratamiento radiante para identificar factores que podrían evitar la cirugía. Actualmente esto está en fase de investigación clínica en estudios prospectivos randomizados y aleatorios. Igualmente, tenemos el privilegio de contar con otros colegas que van a participar activamente en esta actividad. Así está el profesor Dursun Bugra, que es graduado en la Universidad de Estambul en 1979. Ha realizado su residencia, su formación quirúrgica en la Universidad de Estambul en cirugía general del año 79 al 83. Es cirujano general del Hospital de Estambul, cirujano adjunto y profesor asociado de cirugía en la Facultad de Medicina de la Universidad de Estambul. Ha estado en la Universidad de Nancy, Francia, los años 89 y 90. Realiza su práctica privada en el American Hospital de Estambul. Y igualmente forma parte del staff del Departamento de Cirugía General del año 2012 en este hospital. Me place presentar a un compatriota, el doctor Javier Moreno Negrete, un joven y promisorio imagenólogo que está marcando pautas en la imagenología en mi país. Él es el doctor Javier Moreno Negrete, egresado de la Universidad Nacional de Asunción del año 2012. Realizó su formación en imagenología en el Hospital Clínico de Barcelona del año 2013 a 2017. Ha obtenido una beca en radiología intervencionista vascular del año 2017 al 2018. Ha formado parte del staff de radiólogos intervencionistas en el Hospital Clínico de Barcelona. Es staff de una de las clínicas más prestigiosas acá de Asunción del Paraguay, la Clínica Moreno Iribas, y trabaja como intervencionista de imágenes de neuroterapia endovascular en el hospital más grande de la Asunción de Paraguay, que es el Hospital Central del IPS. Estos son los galardones que prestigian y nos dan a ciencia cierta el nivel que va a tener esta conferencia. Mis agradecimientos personales a nuestro traductor. Él es el doctor Roberto López Fernández. Él es probablemente el cirujano mastólogo más importante de la República del Paraguay. Ha sido para él, me ha manifestado en palabras textuales, un privilegio que lo haya invitado para participar de esta actividad científica de tan alto nivel. Muchísimas gracias, doctor Roberto López. Ya se van a dar cuenta por el nivel de su traducción de que este nivel lo puede obtener solamente otro cirujano, pues habla el lenguaje quirúrgico. Así que, profesora Gina Brown, lo invito a iniciar su conferencia y luego disfrutaremos de las preguntas y las respuestas.
Gina, Ricardo has told us so many good things, only good things, marvelous things about you. You are free to start your lecture, please.
Thank you very much. I will share my screen and we will start. Okay. So what I'm going to talk about this afternoon is about what we have learned about rectal cancer, just to summarize in a very short lecture, and where I think MRI is going to help in helping patients to survive this terrible cancer. So I started a lot of this work in the late 1990s, and it was the Mercury study, which we started in 2001, that helped us to advance the use of MRI in the use of staging rectal cancer. The group here, this was in 2000, it was almost 20 years ago, and this is Professor Heald, and this is Professor Quirk, who I learned a lot from in those days, because Bill Heald, as you know, is the father of TME surgery, like Angelita is the mother of watch and wait. And Phil Quirk, he keeps an eye on all of us. He makes sure that what we say is correct. He checks our accuracy, and he also looks at what I'm looking at to see if I am right or not. So that is how I've learned. And I suppose the wonderful thing about spending all these years in studying rectal cancer is the chance to meet everyone, to travel, to teach people. And this is one of the workshops where the radiologists, and I noticed that Bengi Gusses is here from Turkey and Istanbul. She came and we work together now in clinical trials. So, and in Brazil, many radiologists have come and learned how to do the scans and also how to read the scans, and surgeons too. So it's really important that the technique is followed very well, because sometimes if you don't do the scan well, you don't get good results. So that's really important. When I started the research, it was the magic finger that was the best way of staging rectal cancer. And of course, the surgeon's finger is incredibly important for assessing rectal cancer, but it can only give you so much information. And in those days, things were very simple. If the tumor felt fixed or tethered on the finger, the patient received radiotherapy, chemotherapy. If it felt mobile, then they would have major surgery. And the problem with that is it didn't work well enough to give you the kind of results that we can now have. So now, using the MRI, we can make a lot more decisions about what kind of tumor the patient is having and what kind of treatment they can be offered. So not every single patient needs to receive TNT. Not every single patient should go to primary surgery. Some patients can receive local excision, and some patients can have watch and wait. How do we find these patients? How do we decide what treatment to give them? We have to use the MRI scan to help us. And it helps us have the conversation with the patients before they have their surgery. And it also helps the surgeon work out exactly how that resection, how that dissection is going to go and how well it's going to go. So what we have learned is that we have biomarkers. Those biomarkers will help us determine what best treatment to give. So you can give more treatment to patients with a lot of poor prognostic biomarkers, but equally and just as important, you can reduce the amount of treatment you give if the patient has good prognostic factors, because you don't need to give radiotherapy to every single rectal cancer patient because it doesn't help them. And also, if you give too much radiotherapy, it means they cannot have radiotherapy for other cancers in the pelvis. So the prostate, the bladder, the cervix and uterus. Once you've irradiated the pelvis, you can't keep irradiating. So it's very important to only use it when you really need to give that treatment. I met Angelita for the first time in 2004 in Europe, but she invited me in 2007 to Brazil, and it was such a great learning experience because this was the first time I understood what she has been trying to do with the Watch and Wait program, and how we can believe that tumors with rectal cancer, when they get a good response to treatment, they do not come back. And her data was very powerful in persuading people in my hospital and in other hospitals around the world that actually there is another way of managing rectal cancer if you have a good response. So I learned from her, but then I also learned that maybe you can believe the MRI scan. If you see a tumor like this and then it disappears with treatment, perhaps it isn't the best thing to operate on these patients straight away. And perhaps by using a combination of rectal examination as well as MRI, we can identify patients who may never have their tumor grow back after treatment. So that's when we started the Trigger trial, which is currently randomizing patients between clinical assessment and radiotherapy versus MRI stratification. So we use the TRG to decide if the patient can have avoid surgery altogether. Now we're doing this in a trial because these are advanced rectal cancers, and everyone is always very worried about what will happen while we're waiting. Will these patients develop metastasis? Is the tumor safe to be left? Is the patient safe to be left? And these are the questions that we're going to be asking in this trial. But one of the things about using MRI is you have a chance to watch what is happening with the tumor before the patient goes to surgery. And that is so important because we can learn, for example, that some of the things that the patient presents with at the beginning, you can make them disappear. You can make vascular invasion disappear with chemoradiotherapy. You can make tumor deposits and nodes disappear. And that's so powerful because it means then the patient starts with a prognosis like that, but finishes with a prognosis that has no vascular invasion, no tumor spread, no tumor at all. So their prognosis has changed from very poor to very good. And we can look at that on the MRI and decide when is the best time to operate and perhaps to give more treatment to improve the chances of this happening, which is a complete response. So one of the things also that we're developing is working, this is Professor Nagdekar, and we are looking at lymph nodes because what the pathologists believe is lymph nodes, sometimes they're not lymph nodes, they're vascular deposits. And we need to understand a better way of separating out what are lymph nodes, which don't cause problems for the patient, versus the vascular deposits, which can cause recurrences and metastases. So this is one example where here, I think in the past, the pathologists may have called this a round lesion. They call it a lymph node, and radiologists also call it a lymph node. But in actual fact, when you look at this on the MRI and on the pathology, we see it is coming from a blood vessel, and this is a vascular deposit. And what we find is that when you have tumor growing into the veins, that this group of patients with tumor deposits, they do much worse than the patients who have node positive disease. So this group of patients we should treat more aggressively because they can relapse. And what we also found is that the lymph nodes is not the method by which patients develop metastases in the liver. It is from the tumor spreading into the veins and then spreading to the liver. So in a way, MRI has given us an opportunity to understand not just how cancer is looking in the patient, but also what features in the tumor result in the cancer spreading to other parts of the body. So if it goes to the liver, it goes via the vessels. If tumor enters into the lymph node, it probably isn't going to do very much from that position. But what we also notice is that patients who have tumor spread in veins also have tumor spread in lymph nodes, but that's the spread into the veins that causes the problems. So MRI has given us an opportunity to understand the pathways of spread, which also gives us an opportunity to prevent those pathways of spread from occurring. And this is where radiotherapy is so important, because if you see a tumor that's growing into a vessel like this, and you see it growing into those vessels outside the mesorectum, it means that you should treat that patient with radiotherapy, because there could be spread beyond into the sides of the pelvis, into the nodes around the pelvic sidewall, but it's through the vascular channels. And this is an example of a pelvic sidewall vascular deposit, because you see the black here is from a blood vessel. That is all a blood vessel, it's not a lymph node. And so it's important, we think, to make a distinction between these little black dots, which are due to blood, versus a lymph node, which does not contain these kind of features. So this is why it's so important. In rectal cancer also, understanding the low rectal anatomy and being able to decide which patient can have an anterior resection and sphincter preserving surgery versus those patients who need APE. We can use the MRI to give us that information, but also to tell us about the safety of the TME plane. So this patient has a low tumor, but actually a TME plane operation can be performed. And of course, when there's a low tumor like this, there are other options, such as giving radiotherapy, and a very early stage tumor, there is also the option of a local excision. So this is, in a sense, the area of interest, because these are the patients who, when we operate on them, there could be anything happening from losing your rectum, having a permanent colostomy, all the way through to organ preservation. And naturally, we want to improve how much organ preservation occurs for these kind of low tumors. On the other hand, when a tumor has spread beyond the mesorectum, you should not be thinking about organ preservation, because it's probably not possible. And in those patients, giving very radical surgery may be their best chance of achieving a cure and surviving their cancer. So when a patient presents with a very extensive cancer, then we have to use the MRI to help the surgeon achieve a cure by removing not just the rectum, but other structures in the nearby compartments. So this is the mesorectal compartment, but then you have the compartment anterior to the mesorectum, which would need a beyond TME exenterative approach. Posteriorly, a distal sacrectomy. Laterally, a lateral dissection, as well as removal of these structures. And anterior above the peritoneal reflection, well, this is a challenge, but increasingly we see an approach that results in removal of extra structures, even as far as peritonectomy. So these are all the different approaches that we can take depending on what the MRI tells us could be possible for this patient. And this is Paris Tekis, my colleague, who has been working with me in some of these more advanced cases, removing more than just the rectum and the mesorectum, but removing the posterior pelvis in order to achieve a cure for that patient. So this is where we are developing, really, is using the MRI to help the surgeon get a good result, to use the MRI scans in theatre even to see where they're going and see what they're doing. The MRI also helps the radiotherapist plan the treatment so that you can actually give a higher dose to the areas where the tumor is going to cause a problem. So if the tumor is going to cause a positive CRM, why not give more treatment to the area where the margin is at risk? Because this area is easy for the surgeon, that's being removed anyway. But this area where it's extending to the margin, is going to be more difficult to achieve a good resection. And also, if you want to get a complete response, then the area to focus is the area where the tumor is advancing, the advancing edge of the tumor, because this area is the last area to regress on treatment. So that's the advanced cancers, but of course, we have early rectal cancers, and actually MRI is so important here because so many patients get overstaged and overtreated, and actually they didn't need it. And this is Svetlana, my colleague and friend, who has been working with me for more than 10 years now, looking at rectal cancer and staging these. And she and I have developed a system for looking at early rectal cancers. So here is a very low tumor. Maybe in the past, some surgeons would give radiotherapy to this very small, low tumor because that might achieve a complete response. But actually, there's no need. This is a very superficial T1 SM2. And in fact, it can be cured by a local excision. And the MRI helps the surgeon plan that excision so that they don't remove the rectal wall, everything is intact, and the patient has a normal life afterwards with no need for any radiotherapy in some of these cases, because if they're very superficial, there isn't any need for additional treatment. So this is the way we're going to do this. We're going to test the approach of avoiding major surgery in rectal cancer that is superficial, that there is muscularis propria in preserved, and tumor has not got into the muscularis propria. We will be testing whether or not a local excision approach with the surgery could improve the organ preservation rate. So this is the way in which we're going to do that. And what we think is that by avoiding a long stay in the hospital, avoiding stomas, avoiding use of radiotherapy, we'll be saving a lot of income for the hospitals, for the country, but also for the patient. They don't have to spend so long in going into the hospital. So this is what we mean by multidisciplinary research. The endoscopists, the gastroenterologists, the MRI, the surgeons, the pathologists, the patients, we all learn from each other to get the best results and to improve organ preservation. So that's just the real summary of the sort of things that MRI and working in the multidisciplinary team, working with the surgeons, learning from surgeons, learning from patients what they want, and learning about the outcomes of these cancers when they have the different prognostic features, how we can improve what we offer patients and improve their quality of life and their chances of surviving their disease without giving too much treatment and without giving too little treatment. This is what it's about. So if you want to find out more, I have many slides, including how to do the scans, instructions about how to use the MRI scanner is all on the website. So you can take the slides from the website, you can download them, and you can share them with your colleagues, with the radiographers, with the MRI scanner systems. And if you have any questions, you can email me or contact me via the website as well. Thank you very much.
Ricardo, you have the word, Ricardo.
Sí. Qué hermosa conferencia, profesora Gina. ¿Ahora se me ve la pantalla?
Sí. No,
Muy
no,
bien.
la pantalla no.
¿Ahora?
No.
Bueno. ¿Ahora?
Ya, sí, ahora sí.
Bueno. Hermosa conferencia, profesora Gina. Hermosa conferencia. Hemos aprendido muchísimo y sobre todo de un nivel muy alto. Vamos nosotros a abrir un debate. Quisiera escuchar la opinión primeramente de nuestro imagenólogo, el doctor Javier, acerca de, primera pregunta, ¿cómo estamos en Paraguay con respecto a esto? Creo que va a darnos una idea de cómo están varios países de Latinoamérica. Igualmente, me gustaría ver una opinión sobre la conferencia dada por la profesora Gina en el sentido de cuánto nos falta a nosotros en Paraguay para poder aplicar este mismo sentido de validez de la resonancia magnética en el tratamiento del cáncer rectal.
Muchas gracias, doctor Fretes. La verdad, a mí les agradezco a los organizadores por tenerme en cuenta y es un placer escuchar siempre a la doctora Brown.
Dr. Moreno, excuse me, could you speak in English, please?
Okay. First of all, I would like to thank all the people here in the staff. It's always a pleasure to listen to Professor Brown. I remember when I was a resident and I was first starting to read these MRI scans. So I always remember fondly her basic AJR papers where I learned a lot from her. So about what the Dr. Fretes was speaking about, in several countries, in South America, we don't actually have very experienced staff in only rectal MRI. But I think that the method is being currently used in every staff and in every clinic. But I think that it would be great using we don't have like templates or things like maybe in your website where I was browsing, and I think that those will be great. I have several questions. I know if there may be two imaging center, but I would like to know what are the thoughts of Professor Brown about 1.5 versus 3.0 Tesla MRR, and what are her thoughts about our futures with the biomarkers. What does she think about radiomics? What does she think about the study of the curve of the histogram curve and things like that? And I read very conflicting information about that, and I want to know her opinion.
I have some opinions, as you might imagine. My view about having spent a lifetime studying rectal cancer and looking at what it does to patients is that if we have a choice to invest our time in studying how the cancer spreads, how it actually looks, and convey that information to the surgeon and the patient, then we will be doing much more good work than looking in a black box for radiomics. I think Angelita's group, they spent a long time looking at omics, genomics, signatures. And the sad truth is that you can find as many signatures as there are people on the planet. And actually, it will not be the signature that tells us if a tumor is good or poor prognosis. It will be us looking at what the tumor is actually doing to the patient. Because it's the practicality of, is this CRM involved? Where is it involved? How high is it? Where is it in relation to the sphincter? Where is it in relation to the peritoneal reflection? How am I going to give radiotherapy to this patient? How is this patient going to stay fit for their surgery? These are the things that decide whether a patient survives their cancer or not, unfortunately, the signature of the tumor. It is a very small part of a very big picture that we have to understand if we are to improve care for patients. I think that AI will help us, but it will help us in the mundane things, like how we measure the size of the tumor, and maybe we can measure the volume of the tumor. But understanding how to treat the patient, how to give the best surgery, that's not going to be from AI or radiomics. That's going to be from radiologists spending time trying to understand what we are trying to achieve when we cure a patient. And being embedded in the MDT, speaking to surgeons on a daily basis, seeing what their troubles are, understanding what patients need from us, that's how we're going to be good radiologists in the future.
Ricardo?
Muy bien. Profesor Darson, muchísimas gracias por integrarse a Latinoamérica. Valoramos mucho su participación y quisiera preguntarle cómo están ustedes en este tema en Turquía en general. ¿Cómo es la medicina entre Estambul y Turquía en general? Y segundo, su opinión personal sobre la implementación actual ya formando parte de un protocolo de estudio del cáncer de recto en cuanto al valor de la resonancia magnética.
Sure, so now you have the word to comment the presentation, and how is the situation in your country? Thank you.
Thank you very much for this opportunity. Dear colleagues, ladies and gentlemen, I would like to express my thanks to the members of Angelita Habr-Gama Foundation for organizing this scientific event and giving me the opportunity to say some words after the excellent talk of Gina Brown. Over the past decades, we know all the advances in treatment strategies for rectal cancer have dramatically reduced the rates of local recurrence. Surgical resection with total mesorectal excision is remaining the mainstay of treatment of locally advanced rectal cancer. But treatment algorithms to improve long-term outcomes needs the optimization of the inclusion of radiotherapy and chemotherapy. And the way for continued advancement rely on true multidisciplinary care. And medical and radiation oncologists, surgeons, and radiologists must each share their expertise as part of the coordinated team. The risk stratification for aggressive treatments or for more conservative approaches were mostly based on radiologic comments of experienced radiologists. And Gina is the worldwide known expert on rectal cancer imaging. Her studies and suggestions are guiding us a lot in the management of rectal cancer in the multidisciplinary management context. In the last years, total neoadjuvant treatment concept, which aims to complete all radiation therapy and chemotherapy with high patient compliance prior to surgical resection, is gained acceptance in the surgical community. This new method leads also to high pathologic complete response rates with local control and good oncological outcomes. Another result of neoadjuvant treatment which changed dramatically the management of rectal cancer is clinical complete response and possible organ preservation with watch and wait policy pioneered by our dear host and friend Angelita Habr-Gama. In our institution, rectal cancer surgery numbers are decreasing in the last years because of the patients followed in watch and wait group with organ preservation. We have 18% local regrowth rate in the group of 49 patients, and after 36 months of follow-up, the overall survival of this group is similar to the group operated patients with pathologic complete response. And the distant metastases were also similar in both groups. For the future, we need new trials for selecting patients who could be a good candidate for complete clinical response. I hope genetic and molecular biology studies will finalize this goal in the near future. From the radiologic point of view, perhaps new high-quality radiologic modalities to detect these patients with high accuracy rates will be in use in the future. I will be happy to learn the opinion of Gina on the implication of artificial intelligence on the primary and post-treatment strategies, and also the possible role of PET MRI on rectal cancer management. These two important ladies, Angelita and Gina, have a great impact on modern management of rectal cancer. It was really an honor to talk in this session. We are waiting for you to Istanbul in October 2022 for the meeting of International Society of University Colon and Rectal Surgeons. For the last 2 minutes, I would like to leave the microphone to my colleague Bengi Gürses from our Department of Radiology. She worked with Gina in London. She changed our mind a lot, especially in the primary risk assessment and the evaluation of post-treatment responses. Thank you very much again.
Hello, Dr. Brown. Once more again, thank you for the great presentation. Your presentation and the images were really very well, as usual. Thank you so much. As a radiologist, abdominal radiologist, I feel myself so lucky because before the pandemic, actually, I had an opportunity to practice GI radiology with Dr. Gina. She helped me a lot to increase my skills about rectal MRI and other GI pathologies, imaging of GI pathologies. She's really an expert. She has lots of ongoing trials and published papers. And also, I would like to emphasize the importance of the reporting templates. I've received all of your templates, you know, when I was in London, and I turned back to my hospital and I'm using these templates. You have a template for everything, locally advanced disease, early disease, beyond TME templates. So, and our surgeons are really very happy about the templates. Thank you very much again. I would like to ask you, do you think the size and number of EMVI changes the prognosis?
Yes, I really do think that that's one of the key features to be watching for when you're examining the rectum. And what I say to radiologists, yes, look at the tumor, look where it is, but then don't worry about the lymph nodes, go straight to the veins, follow the vessels. You know where the inferior rectal vessels are at the bottom, then the lateral vein branches of the superior rectal vein, then the superior rectal vein. Follow each one, because if you don't get into the habit of looking at them, you may miss a very subtle nodule that's growing in them that will cause trouble. Because when you then follow that same vessel away, you find that it's gone to the side wall. It's then, of course, in a patient who has every vein involved, almost you don't have to see the CT scan. You know the CT scan is going to have liver metastases. So that's why it's so important to really pay attention to the veins. And of course, you are taking part in our trial, the Serenade trial, because we are so concerned about venous invasion that we worry about the possibility of liver metastases even at the beginning of their treatment. So we look for liver metastases using MRI. So I think that the use of AI in radiomics and the way in which we sort of model rectal cancer may in part eventually relate to our ability to look at things like vascular invasion and have a machine say, yes, there is vascular invasion. But one of the warnings I would say is we have to understand what we're looking at in order to advance the treatment. So there's no point the AI telling us something if we don't understand why it is so important. So the human involvement is really crucial if we are to use that information to actually improve survival. So we have to understand why does that patient have a recurrence if it has that pattern of spread? And one of the important things I think that we need to study is every time a patient has a regrowth, every time a patient has a recurrence, every time a patient has a liver metastasis, we need to go back and find out, did we know this was going to happen, or is this a surprise? If it's a surprise, what do we learn about this tumor? And that's why, you know, international collaboration within trials will give us those answers much more quickly. And also, I think the other thing is that when you pay attention to those details, you know, we would love to think that you can look at a tumor from a biopsy and know how it will respond to treatment. But the reality is there are so many variables. What did we see in that tumor? What did we report to the surgeon? Did the radiotherapist give the radiotherapy to all the areas of the tumor? If we didn't show the radiotherapist where all the areas of the tumor was, how would they get a complete response if they don't treat the right areas? So there is so many things to take into account that I'm afraid that just looking at the radiomics or just looking at the biopsy isn't going to give us the answer. It's so many things. The nutritional status of the patient, whether the surgeon got out of bed on the right side and did a good operation, there is so many things. So I think that I would love to say radiomics will tell us the prognosis of the tumor, but I'm afraid that there'll be other things that will overrule that, which we have to give more information to our clinical colleagues to prevent. Yeah.
Fabio, please,
Thank you
could you?
so much.
Fabio, could you please manage the question and answer to our invited speaker and commenters, please? You are on mute.
Okay, Gina,
Thank you.
there's a question here. Why Dr. Brown don't believe in genetic interpretation?
I believe in it. I believe that there is a role, but I do not believe that it's the solution. I think that, of course, we see the different manifestations of different genetic profiles of tumors. We see the mucinous tumors, the signet ring. We see patients who have multiple cancers. We see young patients with a genomic predisposition to cancer. Of course, I believe in it, but I think if we to try and improve cure rates, the fundamental thing with cancer is if you remove it all, you will cure the patient, irrespective of the genomics. So I think that the same with any omics is that you have to understand that it can give us some information, but it doesn't give us everything.
For sure. Another question. Hi, Professor Gina. Glad to listen to you again. I'd like to know, what do you think about the case below? Low rectal T3 tumor submitted to TNT, intent to organ preservation. Because of all the edema at the tumor, at what point of the treatment the intermediate T2 really means viable tumor?
The whole question of tumor viability, I think Angelita showed us the answer to this, that you can afford to, what we call in English, give the patient and the tumor the benefit of the doubt in many situations. And that means when we say benefit of the doubt is we should not be in such a hurry to conclude that the tumor is viable. Now, in a tumor that has presented in a very advanced state and in whom you're giving chemoradiotherapy to, there is an anxiety, completely understandable from our patients, and that's certainly what they tell us, that how can you guarantee that while you are waiting, how can you guarantee that the tumor won't spread elsewhere? We have a lot of data from the trials, from Angelita's results, that the rate of metastasis is low. However, what we don't have is what that means in those very advanced cancers that we can now detect with a complete response, because in the past, they were not that lovely white scar that Angelita shows on her endoscopy, that nice disappearing tumor. In our patients with advanced cancer, that isn't a nice white scar. It looks like cancer at the end of treatment. And then it falls upon the radiologist to say, oh, I don't think that's viable. That's a lot of pressure on a radiologist to say that. And not everybody is going to feel comfortable being put in such a position, especially when there is a patient and their life at risk. So that is why I designed the trigger trial, which is a safe way of enabling such patients to be offered watch and wait, when perhaps some radiologists won't be very comfortable, and certainly surgeons will say, in most of the patients in our trigger trial who got watch and wait, the surgeon said, no, there's tumor there. There's tumor there. I can feel it. I can feel it. I can see it, because it looks horrible at the end of, if you've got an advanced tumor, it looks horrible at the end. So for this reason, we set up the trial, and it is working well, because in the control arm, if the surgeon says it's just a scar, it's just fine, they can still avoid surgery. But it very rarely happens like that in the more advanced cancers. But what's interesting is if you watch and wait an advanced cancer, 40% also go into complete response. And that's without TNT. That's just with chemoradiotherapy and watching. So, you know, we have to really learn a little bit more about the way in which advanced cancers can also respond and become disappearing tumors.
Okay, before I put Angelita to talk with you, I would like to ask you, what do you think are the most important features regarding lateral node involvement that we should check before and after radiotherapy?
Okay, so my view about lateral nodes and nodes as a whole is that we put a lot of importance about them, but actually, rather like in the primary tumor, if you imagine that a lymph node can contain some tumor cells, what we probably don't realize is that maybe those tumor cells are not viable in a hostile environment of lymph nodes. So I do believe the Japanese data that when they remove those lymph nodes, they find cancer cells. But I also believe in the European data, which shows that if you leave them, nothing happens. Because I think it's the same thing. You know, you can remove them and you find the cancer cells. You can leave them and the cancer cells are not viable. So I think my approach with the lateral lymph node dissection is that we should not be offering it routinely if the patient has not got other advanced features. So if you aren't going to go and dissect the pelvic sidewall because the tumor has got a confined within the mesorectal envelope, then you can afford to watch and wait. I think the other thing is, in a situation where there's a lot of vascular invasion and the tumor has clearly spread in the form of tumor deposits to the pelvic sidewall, then the use of radiotherapy is the thing that will save the patient's life. Because the dissection, if you recognize the way in which that spread has happened, it has happened because the tumor has not respected the mesorectal envelope and it has disseminated within the pelvis. Dissecting those nodes and removing them will not cure the patient. It will tell you that you've removed some nodes, but the pathway of spread is still there. And no surgeon, I don't believe any surgeon, can remove the whole pathway of spread. And that means that although you might remove more nodes, you haven't saved the patient's life. Yes. And so we must recognize those limitations about the pathways of spread, and that the key to improving survival is a combination of radiotherapy and close MRI surveillance, because if there is a relapse somewhere in the pelvic sidewall, which we cannot predict, you can give further treatment in the form of SBRT or cyberknife or some focused therapy to control the disease.
Great, thank you. I would like to invite Angelita to change some ideas with you. Angelita?
Yes, it's a pleasure. I quite agree with Gina Brown, because we always follow the same rules for rectal cancer treatment. I think that even the large tumors may be treated by neoadjuvant chemoradiotherapy, and many of them may be treated by watch and wait. It doesn't depend only on the size of volume and infiltration. Gina exposed quite well everything I think about. We think the same thing. But before the end of the section, I have to say to all of you, and particularly to Gina Brown, that our radiologists here in Brazil, and Fabio is testimony of this, they learned it. We are receiving reports of our radiologists, wonderful. I think, oh, perhaps it was written by Gina Brown. Many of them. So our country was very grateful for the teaching of Gina Brown, because it improved the quality of our radiotherapists here in Brazil. We are very grateful for you for that. And I am also very grateful to Gina and Bill Hilde for the acceptance of watch and wait, because since the beginnings, the first time I presented my results, they were in my favor against many others, and always with me. Thank you for you, the Englishmen, because of so, watch wait is now accepted, and many patients are not being operated after watch wait, and I'm very happy of this. Thank you very much. Thank you.
Gina, there's another interesting question here. They're questioning you about the role of ultrasound for evaluating rectal cancer. I know the answer, but I would like you to explain to us.
Okay. Well, you know, I think I think ultrasound was the very first step towards trying to improve our understanding of staging assessments. I think that the technology was brilliant at the time. It was much better than CT. And even at the very early days, it was better than what we could do with MRI in the late 90s. But I think time has moved, and ultrasound by its very nature is very limiting in that it's designed to be an endoluminal technique. And I think that in the situation where you need to understand the whole of the pelvic anatomy and the relationship of tumor to the rest of the pelvis, as well as an anatomic nuance like the vessels, like the extramural vessels, like the CRM, these are things that are very difficult to image precisely using ultrasound. And we conducted a study by somebody who really loved ultrasound and used it all the time for their polyp cancer staging. And then we suggested to them, well, you look at the MRIs now of these and see which one is more accurate. And in the end, they stopped doing the ultrasound because you can get the precision. It's like looking at it under the microscope, but in the patient. So of course, you know, that's the answer. But I think that I admire the people who do ultrasound because it's a very precise technique, and that same discipline should be used in MRI assessment. And, you know, the templates, and I'm so proud to have been able to teach the radiologists and the radiotherapists in Brazil, and that they were so open to learning. And I think that's the key thing, is if you keep an open mind, unlearn some of the things, like stop measuring the size of lymph nodes, don't use diffusion weighted MRI in the rectum. If you discard some of the things that are not useful and stick to evidence, then we all progress. I have to say that when I first heard about watch and wait in rectal cancer, I wanted to see the evidence. Angelita presented the evidence. Of course, when you see good evidence, you want to do the same thing. And always, I don't expect anyone to believe anything I say unless you have the data to prove it. So that's the answer.
Thank you very much. Ricardo, would you like to talk something before we finish our session?
Sí, querría aprovechar y hacer una pregunta. En un paciente joven de 31 años que está en el proceso de Watch and Wait y cuyo estudio de resonancia magnética no revela recidiva, 4 años de seguimiento, pero en el PET scan sale una imagen y precaptante en la pared lateral, en el lugar donde está la cicatriz, que endoscópicamente la cicatriz es brillante. Se ve una mucosa normal. La conducta sería seguir observando o hacer una resección local de esa cicatriz. ¿Qué importancia, qué nivel de importancia se le da a el PET scan positivo en comparación de una resonancia magnética negativa?
That's a difficult question. So how much should we pay attention to a positive PET scan if the MRI is negative for regrowth? So I think in a situation like this, if the PET scan is positive, we would consider doing a biopsy if that was the way. If the PET scan had previously been negative and then becomes positive, of course, that's a worrying sign. We tend not to use PET scan unless something changes on the MRI or on clinical examination. So we tend to wait to do the PET scan if there's some reason to do it, because sometimes we think that it's better not to find things on a PET scan because it just creates many investigations that in the end turn out to be doubtful. So our preference is, if there's no change on clinical examination, there's no change on the MRI, and the CEA has not changed, then we would not even consider doing a PET scan. But if the CEA goes up or if clinically there is a change, then we would.
Great.
But
Profesora
I think
Angelita,
she has more.
¿haría una resección de la cicatriz?
I don't know, Angelita, you might want to you have more experience about using PET scan to guide whether to reoperate.
Oh, I trust more MRI than PET scan, because if you have a scar, PET scan may be positive because it is inflammatory component. So I trust more MRI. But I am not always I do biopsy, but in this particular case, I think biopsy should be very helpful, because if positive, then it is a recurrences. But the digital examination, besides MRI, it is extremely important, the result of biopsy. If biopsy is negative, follow up the patient.
Sure. Thank you, Angelita. Before we finish the session, I would like to tell you that we had attendance from India, Bangladesh, Venezuela, Greece, Mexico, Nicaragua, Brazil, Chile, USA, Argentina, Colombia, Bolivia, Paraguay, Ecuador, Spain, Italy, Turkey, Lithuania, United Kingdom, Portugal, and other countries. So the whole world is seeing us now. And we are very happy, in the name of all the friends that helped me doing all the developments of Angelita's Foundation or Angelita's Association. I would like to thank very much, Gina Brown, for staying here with us today, to thank you for the excellent lecture you gave us, and also thank Angelita for giving us the pleasure and the honor to be here with us and to teach all of us during all these years. Ricardo, Dursun, Javier, we'd like to also thank you for the cooperation in the session. And our association will be present next month, in about 2 months from now, with another important lecture. Thank you very much, and have a nice weekend for everybody. Bye-bye.
Muchas gracias a todos los
Thank you very much.
participantes, a los panelistas. Gracias por el honor y por enriquecer la Fundación Angelita Habr-Gama. Buenos días.
Thank you very much, and have a good weekend, a nice weekend. See you next time. Bye-bye.
Bye-bye. Bye-bye. Ricardo.
Bye-bye. Thank you. Very well. It was excellent. Thank you, Gina.
Thank you. Thank you. I really enjoyed that. That was good. It's so nice to see Angelita looking so well. It's so good.
Yeah,
Fantastic.
for sure.
Fantastic.
She seems like a young
Doctor
girl.
Roberto López Fernández,
Yes.
muchísimas gracias. Su colaboración ha sido encomiable y le estamos muy agradecidos. Ha sido un factor fundamental para el éxito de esta presentación científica. Y sostengo, su condición de cirujano hace de que sus traducciones sean perfectas. Muchísimas gracias por esta colaboración desinteresada, doctor Roberto López.
Thank you, Roberto. Bye-bye, Ricardo. Bye-bye, Gina.
Bye-bye.
Javier,
See you, everyone. Thank you. Thank you for
Ingrid,
Ciao,
and
ciao.
Ricardo.
Bye-bye.
Bye-bye. See you soon.